So welcome everybody. This is Ignatius Bao with Conversations with NCAPIP, the National Council of Asian Pacific Islander Physicians.
So this is David. While Ignatius is connecting via phone, I thought we could just get started with a round of introductions from our panelists, and just the question of what made you want to become a physician or nurse, and what type of practice are you now in? I figured I'd start with Melissa Wong.
Hi, good evening, everybody. My name is Melissa Wong. I am a family practice physician. I've been practicing family medicine for over 10 years now in the Chinese community, primarily in San Francisco. There's a lot of reasons why I wanted to become a physician. One of the main reasons are just really fascinated with the human body. I love learning about it. I love teaching my patients about our bodies and all the amazing things they do for us. And of course, as a primary care physician, I really enjoy the relationship that I have with the patients and the community. And throughout the pandemic, I think that actually got stronger. And so I'm really happy to be here to share that with you guys.
Thank you, Melissa, and thanks for being with us. And that's a really encouraging message there at the end. I'd like to go to Mary Joy Garcia Dia, and I think Ignatius is reconnecting, but Mary Joy, would you please introduce yourself?
Sure. Good evening, everyone. I'm from New York. My name is Mary Joy Garcia Dia, and I am the current president of the Philippine Nurses Association of America. So when I was growing up, I was actually fascinated by my aunt who is a nurse, and I have seen her work in the community, and I guess I gravitated towards that profession. And I migrated here in 1988, and I started my work at Bellevue Hospital, which is a city hospital and part of the Health and Hospital Corporation. My initial background was medical surgical nursing, and then I transitioned as the head nurse of a medical unit during the height of the AIDS epidemic, and eventually moved to critical care nursing, where I took care of patients who are mostly ventilated. Majority are on multi-system organ failure requiring hemodynamic monitoring and sedation. So I got fascinated by physiologic alarms monitoring, and that's when I decided to take nursing informatics. So currently I am the program director of nursing informatics at New York Presbyterian.
Wonderful. Thank you, Mary Joy. I saw Ignatius popped back on, but off. So we'll just continue with Yusufal Mamoon. Please introduce yourself. Glad to have you. Hi.
Hi. Thank you very much. Thank you, National Council of Asian Pacific Physicians, for inviting me in this webinar. I'm Dr. Mamoon. I'm a Bangladeshi American physician, came to this country in 1999, but I have been practicing medicine since 2003. I did my residency in internal medicine in Brooklyn Hospital Center, and then fellowship in geriatric, and then currently at Queens Hospital Center. I'm working as a hospitalist as well as a geriatrician. And why I'm a doctor, it's pretty much, it's a long time and I'm in this profession. Basically from my childhood, I want to serve the people. And this as a physician, it's the profession by itself. Whatever I do, it's the helping the people. That's the beauty of this. And during pandemic, it's again, emphasized for everything that is, recognizing everything that this is one of the best profession in the world, to help the people. And also I'm a secretary of Bangladesh Medical Association of North America. We'll talk again. Thank you.
Thank you, Dr. Mamoon, and thank you for your partnership. I want to now turn to Kara Wong Ramsey. Please introduce yourself and give us a story of how you got involved in medicine and practice.
Hello for an introduction. Aloha ahi ahi, good evening everyone out there. My name is Dr. Kara Noelani Wong Ramsey, and I am a pediatrician who specializes in the care of newborns, a neonatologist who works in the neonatal intensive care unit, taking care of premature infants or other babies with illness or congenital abnormalities. The story of how I got into medicine for me starts long time ago, back when I was in high school. I was very fortunate to attend a private school that was founded by the will and trust of one of our late Hawaiian princesses for the benefit of Native Hawaiian children. She understood the value of education, especially at a time where her people, Native Hawaiians, were facing significant disparities in terms of socioeconomic and educational attainment. And one of the models we were raised upon, we would always talk about her intention to raise good and industrious young men and women who would help improve the conditions of the Lahui, the Native Hawaiian people. So I think from early on, I always wanted to think of a way of how can I give back to my community. And for me, I thought of medicine. I did have an uncle in medicine and did have some personal interest in sciences. Went away to the mainland and completed my education up there, but ultimately returned back home here to Hawaii to complete my physician training as a pediatrician specialized here. So I'm very fortunate to be able to come full circle and back in the community where I grew up and trying to help raise up other young pre-med students to hopefully continue on with increasing the number of Native Hawaiians in medicine and healthcare related fields.
Thank you, Dr. Wong Ramsey. Ignatius, can you hear us?
I can hear you, and hopefully my internet will last. So have you finished
Sounds
the
good.
introductions?
Yes, turning it over to you.
Great. So I apologize everybody for my internet issues. So let me start with back to Dr. Mamoon. If you could share a little bit about your experience with COVID. The Bangladeshi community unfortunately had a disproportionate impact that many people don't know. And so if you could share a little bit of your experience.
Okay, thank you, Ignatius. Yes, and I told you uh, 10 work here in South Asian, Bangladeshi, Caribbean, and few Chinese, yeah. And during the beginning of the pandemic, like last year around February or March, suddenly it's the kind of influx of the all COVID patient in the hospital. It's just within few days we saw that whole hospital is occupied with the COVID patient, and even the ICU, CCU, every bed become COVID bed. And in the beginning, we didn't have any guideline. We didn't know that how to treat this patient. We are in some cases we are just observing that people are dying. And every time in the hospital, every couple of minutes, I will say 15, 20 minutes, there are code blue. And it's a scaring situation. All surrounding the hospital are always with the ambulance and this siren. So in the beginning, we are very puzzled, but still we did our best. That's how we are trained up. That's how, we are physician here. On the street, everyone is locked down, but only few, that emergency people are moving around. I have to come to the hospital every day morning, unless I become sick also. So during that time in the beginning, I told you we have started some hydroxychloroquine and azithromycin, oxygen, but just the traditional way, if patient become hypoxic, like below 90 or sometimes below 85, 86, normally we intubate the patient. And those intubated, the ventilator patient, most of them didn't come back. So we did learn gradually. We stopped using the hydroxychloroquine. We are getting every day the guideline from our central, our hospital is affiliated with the Mount Sinai. So they are giving us the guideline, they are following the national guideline and experience. It's mostly kind of experience, like, oxygen, the Citromax. My experience, is now it's a standard treatment is, if D-dimer is very high, if you have suspicion for the clot, you start the anticoagulant. In that time, we didn't know this one. So our team noticed that in a couple of patients has very high D-dimer. It's sky high, and it's very unimaginable. And then, we did the CT scan. In the beginning, the radiology didn't want to do all the tests. I am sure you all know this. Surgery department, they don't want to do any procedure. Everything is just kind of our medicine team or the team who are taking care of that patient. So we saw, by some reason, some way we made, made possible for some CT chest, and we saw that all of our patients with a very high D-dimer has the pulmonary embolism. And from there, before even guideline, we have started, treating those patients. And I will say these are the steps.
So Dr.
We all are
Mamoon,
yeah.
So I appreciate your sharing that experience of being on the front lines in New York. Can you share a little bit about the impact on the Bangladeshi community in particular and how you saw that?
Okay, so sorry, so for Bangladeshi population, a lot of Bangladeshi patients ended up in the hospital. And I told you, for some reason that the Bangladeshi, South Asian, though their mortality, their admission rate was really high. So, and also I tried to, not myself, a lot of physicians from Bangladeshi people, we tried to help the people who cannot come to the hospital. We did some, telephone service, telemedicine was not that popular in that time in our side, but we use our personal cell phone and everything. And also, that it's just a simple, surgical mask were not available in that time. And we tried to collect the surgical mask, distributed among the Bangladeshi community. We have, developed some handout and try to distribute in the community, in the local groceries, that what the basic concept or basic things we need to do for the COVID to avoid the COVID. And also we have participated in the television program, just in the direct program. I remember, many programs were, participated live telecasted, and we have answered the question, what are the their common concern and how to protect ourselves. But it was really a very scary time in that time.
Thank you. Thank you for sharing. So, Dr. Garcia Dia, you also were in New York in that time period. Do you want to share a little bit about your experience?
You're mute.
Absolutely. When the pandemic hit New York last year, I had to step in temporarily as the president of our organization because our current president at that time got sick of COVID together with her husband. And unfortunately, she lost her husband because of COVID. And that really impacted our community, and it became more personal for our organization. In fact, when the media shared that 30% of the mortality rates of healthcare workers, particularly nurses, are coming from Filipino American nurses, we were so concerned, and other academic researchers and community leaders came together to look at the data and really understand what's going on. What are the contributory factors that could be impacting our Filipino American community in comparison to other races? And that's the challenge that we have in just trying to get data, because as we all know, there is no data that's really specific to disaggregate our Asian community. So from that initiative, the group formed together and wrote a position statement addressing the Biden-Harris administration to look at data disaggregation of our Asian community. In addition to that, our organization launched our COVID-19 task force so we could gather information from our different chapters all across the United States to understand what's really going on in the ground. Because to Dr. Mamoon's point at that time, we didn't really know what's going on, how the treatment is being facilitated. And we were able to just get reports from our various chapters. So from there, we launched our Heal Our Nurses campaign because majority of the information that we gathered is really related to the trauma that our nurses were experiencing at the time. Some of them are just devastated seeing their own coworkers being sick of COVID. And eventually, we know several of our members passed away as well. So that was really a sad time for us, even up to now.
With two providers who were so close to the the epicenter of the pandemic in New York City and sharing those experiences, thank you both. I'd like to turn to Dr. Melissa Wong to talk a little bit about your experiences while Ignatius reconnects to the audio.
Yeah, so thank you for your perspectives. As a family physician, I actually have much more experience on the outpatient side during the pandemic. And, as we know, when it first started, February, March 2020, I was actually the medical director of an urgent care, outpatient urgent care, and also my own private practice. And during that time, we had, known so little about what was going on. We didn't have any resources. We weren't really connected with any hospital, didn't have access to testing, vaccines. And, in the very beginning, we even physically had to put up barriers. Patients would come in without masks. We'd actually physically lock the doors. And so even though San Francisco never really experienced a surge like New York, fortunately, we still suffered a lot of the side effects of anxiety, depression, isolation, even among the community doctors. And so I think it was really important that as soon as we kind of got over the initial hump, we kind of came back together, and the community physicians, we all got together and kind of figured out, what do we have to do to take care of our patients? If they're not in the hospital, they're still coming to us. And so right when the vaccine started, again, the mass vaccine sites were not accessible to our community. They were in places that were not convenient. There was a lot of language and technology barriers. So out of just 2 primary care doctor offices, we vaccinated to date about 50,000 patients already. And a lot of the success is really, again, from the community doctors coming together. We made sure that each clinic was staffed with a physician, so a face that we all know. So it would be like your pediatrician who is vaccinating your kids from birth. Me, gave you your last flu shot. So it was people that really had a face and a trust in the community. And so that's been really helpful for us, just that collective energy of kind of all coming back together after being closed off for so long.
Thank you, Dr. Wong. And I'll turn to now Dr. Kara Wong Ramsey. Tell us a little bit about your COVID experience, during this pandemic in Hawaii.
So as I mentioned earlier in my introduction, so my clinical realm primarily deals with newborns in the intensive care unit, but I also have additional roles in the community, particularly regarding community outreach and education. So in the beginning of the COVID pandemic, our state became aware that COVID was disproportionately affecting certain groups higher than others, in particular Native Hawaiians and Pacific Islanders. Unfortunately, we did not have very good disaggregated data. Traditionally, Native Hawaiians and Pacific Islanders have always been aggregated in a single group in a lot of other reporting measures. But in our state of Hawaii, where we have a variety of different Pacific Islander cultures who have very different histories here in Hawaii, and our more recent cousins and neighbors who've come from other places within the Polynesian Triangle have different histories and situations compared to Native Hawaiians here. Knowing this, number of grassroots organizations came together. As a member of Ahuhui na Kauka with the Native Hawaiian Physicians Association, I was invited to be a part of this collaborative. In addition to physician and other healthcare organizations, there were other community health organizations that stepped forward and really decided to take it among ourselves that we need to do something for our community because nobody else is reaching out and helping us. So we created the Native Hawaiian and Pacific Island 3R team. The 3R stands for response, resilience, and recovery. Among that, we set up multiple different communities, including public policy, communications, and social recovery outreach, and data and research. Particularly, and I'll speak to my experience on the data and research community and the community education sides. And those were the two communities that I was particularly involved. From the data side, as I mentioned, we knew early on that data was significantly lacking. We know later on in the pandemic that what did become a federal requirement that with every COVID test, there was now a requirement for race to be associated with it. Unfortunately, the requirements for race were at the OMB, the federal level. So Native Hawaiians and Pacific Islanders lumped together. So we worked with other organizations and with Department of Health to try to disaggregate this further. Our Department of Health made a strong effort to reach out and contact these positive cases and through interview, able to try to extract some more nuances of the racial and cultural and language background of the different groups who were becoming positive, which did reveal some striking trends. We saw that in the beginning of the pandemic, our Pacific Islander sisters and brothers were being largely disproportionately affected by the pandemic, particularly our Micronesian sisters and brothers, or Samoans. And interesting, later on, after the vaccines became more largely available, we interestingly saw trends where infection rates among other Pacific Islanders were going down, yet were rising among Native Hawaiian populations, pointing out to the greater need for different strategies and messaging and outreach towards certain targeted communities. On the field of the community and education outreach I've done, on behalf of Ahuhui na Kauka, myself and several other Native Hawaiian physicians and other Pacific Islander physicians participated in numerous webinars for the public in an effort to combat a huge rise of misinformation that was preventing people from getting out there to get tested or understanding the importance of masking or seeking out vaccinations. A lot of our outreach and grassroots communities also rose up to help the communities in greatest needs. For example, in some of our Pacific Islander communities, especially with recent immigrants, there were huge language barriers where English was difficult to comprehend, and there was not a lot of outreach for some of these more rural locations. Some of our grassroots efforts sent groups out there who spoke the language and could go into these small communities, make themselves available to answer questions and bring testing capabilities and vaccines out from the urban hospital locations and out into these rural communities. Some of these communities needed help with things like trying to quarantine or trying to find places to quarantine. In Hawaii, where our cost of living is astronomically high, multi-generational living is the norm rather than the exception. And with multi-generations living in a relatively small household, it's extremely hard for families to quarantine if one member becomes ill with COVID. So there's a greater outreach to get food to these communities, to find hotel lodgings where they can stay. Some of these efforts are continuing today, especially now with the recent approval for COVID vaccines for children, and more recently children of a younger age. We're continuing to try to have more of our community health groups get out there in the community, try to seek out volunteer health professionals, nurses, or physicians to be out there and be available to talk to the community. Traditionally, there has been a lot of distrust in some of these communities against traditional Western medicine, these notions of the government and pharmaceutical industries not looking out for the best interests of Native Hawaiians and other Pacific Islanders. And rather than trying to make people feel that they're being forced into an uncomfortable situation, I think a lot of us have tried to be available ask questions, and try to create a safe space out there in the communities where people feel a little more comfortable in opening up, and try to answer some questions and concerns the community has around COVID vaccinations and other protection measures.
Thank you, Dr. Wong Ramsey. You brought up key policy issues for Asian American, Native Hawaiian, and other Pacific Islander communities. Talked about what it takes and how it's necessary to come together organizationally, working on policy with the public sector, with the private sector, cultural factors, questions of resources and access. You brought up the social determinants of health, and as well as kind of a notion of solidarity. You know, you use the term our brothers and sisters, and with such a heterogeneous acronym, we all advocate for parts of, and as a whole, that seems to be a really good benefit that during this time, there has been more advocacy for Native Hawaiians and other Pacific Islanders, not maybe where it needs to be, but I think that's something that we see at NCAPIP, have seen in the past year in terms of how we're exercising our voices. Dr. Mamoon, you've seen these disparities at play in your clinical work. You noted, the high rates among Bangladesh Americans. Obviously, Mary Joy working organizationally, being thrust into a leadership position during a crisis, and creating a national campaign to address disparities in terms of what's happening to the Filipino American nurses, and Dr. Wong literally providing access to a community in need in San Francisco, Chinatown. I wanted to ask the panel, because I think Ignatius's technical difficulties might take him out for the rest of the night, but what do you think of the notion of providers as trusted messengers in the community? What does that mean to you? And feel free to reflect on experience, of course. I'll start with Dr. Mamoon.
Okay, thank you. Actually, the area I'm practicing or living in New York, I think it's a little different than the other places could be. It's true that our community, the minority community, they are affected really in the high number of COVID. It could be that they live in the area. It's a very dense area. It's an apartment building. Couple of 100 families are living there. Okay, that's one. But from the data, you say that it's really lacking. There is no data about our community, and definitely the Pacific Islander or any other islander. There is no data available. We tried from our BMNS side. I think this is the first time during COVID time we have started collecting the data. But the national level is more important, right? The data collection and this communication basically bring the attention from the policymaker, and that's how we can help our community. But a little different thing I want to mention, that in our community in Jamaica or New York City, the city basically is really did a very, very a great effort. They have supplied the free food, okay, and they have did everything, like even in the language in our area, they have provided the Bangla language, hot channel, those things, and the TV. And also one more thing is for the vaccination. You cannot imagine that it's a so high rate of the vaccination success in our community in that neighborhood. I will say most likely it's more than 90%. They have provided vaccine. It's so easy, available, accessible. It's tremendous effort from the city. That's how I want to mention that from the policy making side, for the national level, maybe we need to communicate more. But as a city, it's maybe New York City, the cosmopolitan, and it's a city of the immigrant. We got the huge support from the city government officials.
Hi, it's Mary Joy, and thank you so much for that question, David. Before assuming the role of PNAA president, I was in fact volunteering as chair of Kalusugan Coalition. Kalusugan means health in Filipino language. And we actually work hand in hand with another researcher through the NYU Center for the Study of Asian American Health in trying to understand healthcare barriers. And one of the things, which to your point, is having the trusted messenger in the community. When we were trying to understand what are the healthcare barriers, majority of those respondents during our interview is that they prefer someone who would be able to understand and speak their language, especially for our elderly population. They feel more comfortable in talking to someone that could speak the language, so to speak. So that's why we were so motivated in trying to translate some of the information that we have during COVID-19. In fact, we work hand in hand with the Asian Pacific Islander American Health Forum in translating some of the terminologies in Tagalog, and also some of our members who speak Ilocano, especially those that live in Hawaii, prefer to have it in that language. And I think that was very effective in terms of like being that messenger when we try to tailor those social media postings that we have, because people can easily relate and really resonate with them what that means from a cultural perspective. So I think having that trust by representing our community and speaking the language and translations is really helpful during these times.
And then I'll leave it open to Dr. Wong and Dr. Wong Ramsey, whichever of you want to jump in first, or it's up to you.
So I can just speak into that too. The idea of physicians as trusted messengers, I think, is a powerful and strong concept. From my perspective as a pediatrician, we know that studies have shown when it comes to COVID vaccines in children that parents, when they're trying to make decisions about COVID vaccine, they do see their pediatricians as someone who is a trusted messenger to provide information and is a preferred location of where they would want their child to receive the vaccine if they do decide it. I do believe it is a strong duty of us as physicians and healthcare leaders to get out there and provide messaging to the community, given our background as experts in healthcare. As a pediatrician, our role is not just the individual child, but the whole family as well. Obviously, my newborn babies in the ICU are not eligible for the vaccines, but their parents are. We've made it a common practice for those of us who are admitting babies in our neonatal intensive care unit to ask the parents when they are getting admitted if they're vaccinated, and start opening up and having that conversations if the parents are willing to talk about it. Elsewhere on the idea of communications, personally, I've taken it on myself to do some more social media based platforms for outreach and education. With the rise of TikTok and staying home with my kids and trying to homeschool, to basically do home it with them before their schools went back in service, I became a little more proficient at using TikToks. And I've learned that using social media, including TikTok, is a powerful and commonly used medium for a lot of physicians out there. And after seeing a lot of excellent examples from other physicians who've done a lot of education, ranging from things, whether it's personal health issues or COVID or epidemiological issues, taking on those cues, I've tried to branch out a little bit on my own and talk a little bit about my experiences as a physician, being one of the first people in my state of Hawaii to get the vaccine, talking a little bit about side effects I experienced and why I believe people should still get it, and all the way to my more recent videos talking about why I've decided to vaccinate my own children against COVID.
And Yeah, we have a pretty similar in terms of like reaching new boundaries or passing new boundaries in terms of using social media. I don't have a TikTok or Twitter, and I don't have Facebook and those kinds of things, but because the pandemic really closed us off from each other, we also learned that we actually kind of went back to, again, the community medicine part of it. We try to be as accessible as possible to all the patients. We called the patients, every single one of them in our panel, to check on them during the COVID, telling them we're open on telemedicine, teaching older people how to use Zoom. We tried to really expand our outreach. And we even started some YouTube videos, things that we've never done before. But these are scalable. They can reach people in their homes, and they can reach people with different language skills. Even, again, our older patients, they don't know how to use Zoom, but they can get on YouTube. So I think it was just a really good way to put our expertise and also the trust that patients put in us to good use, because we can really scale that using social media.
So just to briefly summarize, because I thought all of those were really beautiful. Dr. Mamoon talking about kind of reporting the truth and the reality of what's going on, including the good that's happening at local and state levels, and making the comment that maybe one good thing that can come from this is having those successes that are happening at the community level in places like New York City and places like San Francisco, and getting that attached to kind of the national conversation. That's an important aspect of being the messenger. Mary Joy, for really talking about coalition, the importance of that, the role of the communicator, and how important literally language is to communicate to patients and to communities. Dr. Wong Ramsey literally talking about the ways to connect as messengers, and leading by example, from getting the first shot, one of the first folks to get the vaccine, to communicating in the medium that a lot of folks in the community reside in and get their information from is important for messaging. And then Melissa talking about the telemedicine, the increased outreach from teaching the elders to Zoom. Yeah, these are great. I wanted to say there was a question from the audience from Antaki Rai, I hope I'm pronouncing your name right, who asks, I was wondering if all of you had any experience with handling the COVID disinformation, misinformation, or vaccine hesitancy in the AAPI communities. Was it different from the European American groups? And that's open
Hi,
for
Mary Joy. I know that's a very challenging question, not just for Filipino American communities, but also for other races. Personally, I did experience that. It was hard for me to convince my in-laws with regards to the effectiveness of the vaccine. And I worry about them because they're elderly, right? They're like about 80 years old. And it's only through honest conversations, I think, that you would be able to explain the benefits of the vaccine. And what's helpful too is our collaboration again with other organizations that have resources that could provide credible sources of information, like, for example, through the CDC. In fact, we have facilitated multiple listening sessions and also requested some of our members to share their stories. And I think that's what's very powerful. One of our members was actually sharing his story in being part of the initial trial for the vaccine and what it meant for him in terms of making that meaningful and really doing good for the community. Other members of our community also shared different perspectives on how they have experienced the side effects of the vaccine, which is common, right? But at the same time, they also feel much better that they were able to do it. And I think those constant conversation and consistent conversation, that's the only way for us to be able to counter the misinformation that's out there in the media.
I'm Dr. Mamoon. At my practice, it's really, I told you at the beginning that our vaccination rate is really very good. Only thing, very few, I also less than 5%. I saw that some kind of misinformation or their disbelief are there, and mostly it's not elderly people. We have just the middle-aged people, and a kind of I saw that in more educated, formal education, the people who have the formal education, they have some kind of disbelief, and few of them, they persistently resisting the giving the vaccination even now.
For my community, I feel like one of the biggest challenges was actually misinformation from other countries, because we're so connected. Other countries actually have very different approach to COVID than the United States, I would say. And so the WeChats, all the other YouTube videos from other places, they actually did pose a lot of challenges for us. But like the other panelists had said, staying open, staying connected, listening to the patients, trying to really figure out what they're actually concerned about, usually actually just more fear rather than actual the information. And so kind of working with them and constantly talking and being available to the patients when they have questions, I felt like was really helpful.
I agree, misinformation is one of the top 10 threats to public health, according to the World Health Organization, and especially true during this pandemic. I think, like the other panelists have mentioned, patients' understanding is key. As a pediatrician, we are no strangers to vaccine hesitancy. It is a common theme for routine childhood immunizations as well. And some of the themes that run similar are that directly confronting people with information that is against or contrary to the beliefs doesn't always lead to the best outcome. Sometimes it just results in people just digging in a little harder to their firmly held beliefs. No one likes to be proven wrong. So I think, like others have mentioned, taking a more subtle approach and trying to ask open-ended questions and probing, like, well, why do you think that is? What about this? And kind of answering with more probing questions to help our vaccine hesitant patients try to reach the conclusions on their own with their own independent thinking. I feel is one of a helpful strategy that helps. Other things that have been helpful is stressing the importance of health for the community. We know that traditionally COVID has not affected younger people as severely as our older people. And given that among a lot of Asian and Pacific Islander communities, ohana or family, the community, the lahu are very important concepts. And harping on this idea of we need to protect our kupuna, our elders, and do our part. It's a kako, it's a together collective effort to protect everyone by getting the vaccine, even if you are a low risk, healthy, young individual. Everyone plays an important role in helping our community and our elders and our children too.
Well, thank you all for a wonderful answer to that question. I know because of the technical difficulties, and apologies again, and on behalf of Ignatius as well, because that took a couple of minutes from us, and I saw there were a couple of great questions in the chat box. To the panelists, are you okay staying a couple more minutes to maybe answer one more question?
Sure.
Okay, thank you so much. So I'm going to make this a dual question, and then we'll close off for the night. And thanks everybody for joining again. The dual question is, what have been your frustrations in providing COVID services to our AANHPI community? Frustrations in providing COVID services, and then are you optimistic about the future for the pandemic response? And whoever wants to speak.
One of the frustrations is the repetition, particularly around misinformation. I think all of the panelists have brought up some really good points about establishing that rapport and connection with our patients, but it does get tiring for an individual to repeat that information, get that sense that you're feeling like a broken record. And sometimes there are some people who are not in a position where they are receptive to receiving new information or different information from what they receive, despite our very best efforts. And sometimes it is frustrating to feel that sense of defeat that, well, I was not able to convince this individual patient of their decision around COVID or vaccinations. And as healthcare providers, the repetition of this can be exhausting and lead to problems with burnout. With the pandemic, we've been seeing large numbers of healthcare providers actually exit the field due to feelings of burnout, due to feelings of frustration with dealing with patients who have misinformation, or dealing with a public or patients who are outright very dismissive, aggressive, sometimes outright assaultive in some cases. And I think one thing that gives me hope for the future is that no one is an island. Sure, we're an archipelago of different islands out in the Pacific, but we are a nation of multiple different islands together within this archipelago and island. And we're here for each other. What gives me hope and faith is seeing forums like this, where we're able to come together with other healthcare leaders from different communities, share some of our struggles, some of the key aspects that we thought was helpful, and learn from each other, and also connect with other people who understand the frustrations we're going to. I also find hope in seeing the renewed interest and vigor among our community, not just among healthcare individuals anymore, but even among non-healthcare individuals. There are so many people in our community out there, especially with the recent rise of the Delta variant, and everyone's understanding that, we all have a role to play, whether or not we are a professional healthcare educator. Everyone has a role to play in it, whether it's something like doing a small little presentation at your school or workplace, or even if it's as simple as bringing a conversation up with your close friend, your auntie, your uncle, and say, hey, what do you think about vaccination? We know that over time, people having these conversations with people they love and trust, whether it's a trusted family healthcare provider, or whether it's someone in their own community, their elder, their church leader, or someone they look up to their family. And over time, these conversations can be helpful in turning the tide, in helping us turn the fight against COVID in our communities.
Hi, it's Mary Joy. I think what's out there right now, and even based on the survey that was conducted recently by the American Nurses Association from the frontliners themselves, over like probably 75% are feeling stressed and frustrated, right? We are now almost close to 2 years with this pandemic, and majority of our nurses are pushed to being burned out. In fact, you could see in the news the shortage of staffing, not only here in New York, but all different parts of the country. So I think that's what's frustrating in terms of providing COVID services in the community as well. Everyone wants to go back to the new normal, but it seems like there's always a recurrence in terms of like the mutation of the virus, and everyone is on the edge and fearful on what would be the future. But I think to Dr. Kwong Ramsey's point, it really brings out the best in our community in terms of staying resilient during these times. I think there's a silver lining in what have happened to everyone, by the way that it had really made the issues on healthcare disparities in our community more obvious. And now people are really working together in trying to address these disparities. and really making our voices heard and be more united in the forefront. And I think that's what my hope is in terms of really pushing policies in addressing our underrepresentation and looking at data disaggregation for our Asian community.
Thank you both. I want to go to Dr. Mamoon, and then I'm going to have Dr. Melissa Wong take us out. But this has been a wonderful conversation, and thank you all.
Okay, thank you. This is Dr. Mamoon again. The frustration, my frustration is mostly that whenever the patient are not, listening to our advice or the standard protocol, like anyone has the COVID at home, the mild case, they are not maintaining the social distancing. They are not using the masks. And this really, it's very painful. We have seen a lot of sick patients, a lot of death, but still it's little relaxed condition. You'll see that, especially our South Asian or I will say in my community, they will rush for the shopping. They will rush for the grocery in not using that mask and the social distance, not maintaining the social distance. And I see it every day, and it's really very, it's very painful to me to see these things. And I'm really optimistic. Vaccine is working, you saw. And with the help of everyone, all together, we'll face it and we'll overcome it. Thank you.
Yeah, kind of to also echo some of what the other panelists had said. My biggest frustration, I think, is that since the pandemic started, I feel like everyone's anxiety levels have just been raised, and then we kind of hit the panic button multiple times over and over and over. And every time we have a success, the vaccines were a great success, but then we had then a rise in protests. Our clinic has been vandalized several times. Pharmacies around have been having the same problems. I'm sure you've heard about it on the news. And so every time we seem to have some kind of victory, that seems to be something else that kind of comes along. But I do remain hopeful because, just like we're talking about today, sharing our stories with others is really inspiring. Hearing other people and how they're managing, and just seeing everybody just keep showing up every day and keep showing up like we usually do. So that's very, very hopeful for me.
I can't think of a better note to end this conversation with NCAPIP on. I want to thank everyone for their questions. I will try to contact the panelists and get some more answers to these, but thanks for your participation and contributions. And thanks to our panelists, Dr. Melissa Wong, Dr. Mary Joy Garcia Dia, Dr. Kara Wong Ramsey, Dr. Yusuful Mamoon. Such a pleasure. We hope we were able to continue to collaborate with you all and support the work that you do, and help bring these success stories and these observations to the national policy arena. So thanks everyone, and good night.
Good night. Thank you. Bye.